Hello and welcome everyone to tonight's webinar on the new lung cancer screening program and what it means for the ACT. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. Also with me is Kunal Mohiti, the events lead at Capital Health Network, and of course our panel of experts, which includes local respiratory physician Dr. Daniel Wang from the Canberra Hospital, John Lee from Telstra Health. John is the head of engagement and communication for the National Cancer Screening Register. Professor Vivian Milch, who is the Medical Director at Cancer Australia, Katrina Anderson, who is the Director of Lung and Pancreatic Cancer Initiatives at Cancer Australia, and Jen Sloan from the ACT Health Directorate. Jen is the Senior Director and Program Manager of the National Lung Cancer Screening Program in the Population Health Division. First, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. And we also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So housekeeping, everyone has been muted apart from the presenters. And if you have questions, and I'm sure there will be questions, please type them into the Q&A box on your Zoom panel, not the chat window. So the Q&A box, we'll have a Q&A session once all the presenters have spoken. And Jen Sloan and Professor Vivian Milch will join us for that panel Q&A discussion. So our presenters tonight are in order. Katrina Anderson. So Katrina is the Director of Lung and Pancreatic Cancer Initiatives at Cancer Australia. Katrina has been leading Cancer Australia's clinical workstream to support the National Lung Cancer Screening Program. Dr. Daniel Wang. Daniel is a respiratory and sleep physician. He's the current director of the Respiratory and Sleep Department at the Canberra Hospital and is also the medical director at RSCM, a private medical specialist centre with outpatient and in-laboratory sleep services. Daniel is committed to medical education and was the previous Director of Physician Training at Canberra Hospital. Daniel is the departmental clinical lead for lung cancer and is eager to better collaborate and consider creative solutions to improve diagnostic services for lung cancer. And John Lee. John is the Head of Engagement and Communications at the National Cancer Screening Register. John has over 15 years experience in the field of cancer screening, both in the UK and in Australia, and he is passionate about improving participation in cancer screening programs and integrating the broader healthcare ecosystem to help improve health outcomes for Australians. Okay, thank you very much, and over to our presenters.
Thanks, Leonie. I've just opened my presentation. All right, can you see that okay?
Yep, that's good.
Perfect. All right. Well, thank you firstly for having me present today. Excitingly, we are 8 days out from the program commencing. And I would like to first start by acknowledging the traditional owners of the lands that I'm joining from today, and that's the Ngunnawal people, and pay respects to elders past and present, and extend that to any Aboriginal and Torres Strait Islander people joining our webinar tonight. So I'm going to set the scene and give a bit of an overview of the program and also what we have developed ahead of the program commencing next Tuesday. So the program has been co-designed and implemented in a partnership approach with the Department of Health, Disability and Ageing as the lead, with Cancer Australia and NACCHA, which is the National Aboriginal Community Controlled Health Organisation, as partners. And to deliver, we have engaged experts in the sector, and that includes the University of Melbourne, Lung Foundation Australia, Daffodil Centre and Cancer Council Victoria, Royal Australian New Zealand College of Radiologists, TSANS and Heart of Australia. So as I said, the program commences 1st of July. The program will deliver targeted screening to high-risk individuals on a 2-yearly basis. And eligibility to participate in the program is assessed on risk-based eligibility criteria, which was recommended by the Medical Services Advisory Committee, MSAC. So people are eligible to participate in the program if they are aged between 50 and 70 years. They are asymptomatic, so show no signs or symptoms suggestive of lung cancer, and they currently smoke or have quit smoking in the past 10 years and have a history of at least 30 pack years of tobacco cigarette smoking. And importantly, those who are symptomatic need to be referred and treated or investigated according to the Investigating Symptoms of Lung Cancer Guide and Pathway. So today I'll go through the elements that are now in place to enable the program, and I will deep dive into the screening assessment pathway and those supporting resources and the National Communications Campaign and healthcare provider education strategy. Also supporting the program are some key infrastructure. So we have established 2 program-specific MBS items, which will enable the free low-dose CT scans under the program. The program will use existing low-dose CT infrastructure in private and public settings, as well as mobile screening. So Heart of Australia will deliver 5 mobile screening trucks to provide screening to some rural and remote communities. The NCSR has been expanded to support the National Lung Cancer Screening Program. So the NCSR supports cervical and bowel screening programs and will now provide that safety net for the lung cancer screening program. So we'll provide the communication and reminders. We'll receive the low-dose CT scan reports, and we'll also ensure that the participants are on the right screening journey. And John will go into more detail on the NCSR shortly. So this is a snapshot of the screening and assessment pathway. So like other cancer screening programs, we have developed a screening and assessment pathway for the National Lung Cancer Screening Program, and this really defines the parameters of the program. It is evidence-based and unique for the Australian setting. The program has then been designed around this pathway, and the key steps include promotion, recruitment, eligibility and assessment, enrolment, undertaking the scan, the assessment of the scan and reporting, and then management of those next steps from the scan. So in terms of the first step, as you can see here, is promotion and awareness, and this will be supported by a national communications campaign and healthcare provider strategy. We really want to encourage potentially eligible people to come in and see if they are eligible for the program. And importantly, smoking cessation is integrated from this point and across all steps of the screening and assessment pathway. The second step is recruitment. So the National Lung Cancer Screening Program is different to other cancer screening programs. As this is a targeted program, the NCSR does not invite people to participate like it does for bowel and cervical screening. So potential participants will enter the program via 4 entry routes. So the first of those is organised entry. So for example, a primary care practice may go through their database of patients, identify those who do have a history of smoking and invite them to come in and have an eligibility assessment. The second is opportunistic entry. So a person may already be at an appointment with their GP. They then discuss eligibility and participation in the program. The third is facilitated entry, and this can be from any healthcare provider. It could also be that someone is speaking, for example, to a quitline counsellor, and they're encouraged to make an appointment with a healthcare provider and have that eligibility assessment. And the fourth is self-identified entry. So someone may see the program advertised and want to see if they are eligible to participate and make that appointment with their GP to have their eligibility assessed. So potential participants will then need to see a requesting practitioner, such as a GP, to have their eligibility assessed, have a shared decision-making discussion to make an informed decision to participate, have their suitability to undergo a low-dose CT checked as well. If eligible, the practitioner will then enrol them as a participant via the NCSR and complete a request form for the low-dose CT scan. And you can see this request form on the screen now. So the program does have a program-specific form and encourage healthcare providers to use this form. It does include information specific for the program for that referral process. So identifies that the person is eligible and a program participant, so that the right MBS items are used. It also includes clinical information that's needed by the radiologist when reading and reporting the scans, such as a family history of lung cancer. The next step is the low-dose CT scan, the assessment and reporting. So the participant will have their scan at a radiology clinic or on a Heart of Australia truck if they are in a rural or remote community which offers mobile screening. The scan is then read and reported, read and assessed by radiologists using the National Lung Cancer Screening Program nodule management protocol. And this has been designed in line with MSAC's advice using PAN-CAN for baseline scans and then lung rads for subsequent scans. The radiologist will then report the scan using the National Lung Cancer Screening Program Structured Report. And this has been developed for the program to ensure that we have nationally consistent reporting. The report is also sent to the NCSR as well as the participant's requesting practitioner. So the scan will be classified into one of 6 categories. Very low risk, and those participants will return for screening in 2 years. Participants with a low to moderate or moderate risk finding will have a follow-up scan in either 12, 6 or 3 months. And then those with high or very high risk outcomes will be referred to a respiratory physician linked to an MDT for further investigations. Participants may also have actionable additional findings found on their low-dose CT scan, and these will be reported by the radiologist and managed by the requesting practitioner as per existing guidelines and pathways. This next step is around results and reminders. So the NCSR will notify participants and their healthcare providers when results are ready. If a participant has a very low risk finding, the NCSR will let them know this result and to return for the next scan in 2 years. If the participant has a result which requires further action, the NCSR will let them know to make an appointment to see their doctor to discuss those results and the next steps. And the NCSR will then send reminders when participants are due for the next scan. So this gives a snapshot of the screening assessment pathway and the range of healthcare providers that are involved. So from detail in the pathway, it does demonstrate that there are a lot of healthcare providers involved in the pathway. In terms of primary care play a critical role across the pathway, particularly around those early entry points and getting people assessed for eligibility and into the program, as well as supporting the smoking cessation, support for those people who still smoke, and also helping to make the referral and managing those results and next steps that come from the low-dose CT scan. So nurse practitioners will have an expanded role in the National Lung Cancer Screening Program, being able to request and manage the results of the low-dose CT scan. The department undertook a scope of practice review to review the role of nurse practitioners to support enhanced access and participation in the program. The expanded role was considered and was approved by government, and the department is now updating training materials and engaging providers on what the expanded role entails for the program. So we have developed and now published a suite of program materials for healthcare providers across the screening and assessment pathway. So this includes the National Lung Cancer Screening Program guidelines. These are really a how-to guide for the program. They provide recommendations and practice points for every step of the screening and assessment pathway, as well as program considerations such as providing culturally safe care. The National Lung Cancer Screening Program Nodule Management Protocol, which I mentioned before, is also published on the department's website. And related to this is guidance that was developed by RANSCA on additional findings. This is also available on RANSCA's website. And Cancer Australia is currently finalising some additional guidance for additional findings. We've been working on this with RANSCA and RACGP, really as a kind of a quick reference guide to support primary care in linking to existing guidelines and resources for any additional findings that require further investigation and management in primary care. And then we do have a comprehensive suite of information and education resources. So there are resources that are specific for the radiology sector that we've been working on with RANSCA, but then we also do have other information materials and CPD e-learning modules, education modules as well. This just gives a snapshot on some of these. So we have resources which are covering the whole program as well as specific steps of the pathway as well. So in terms of the e-learning modules, these, as I mentioned, are CPD accredited with RACGP, with APNA, NUTSI-WIP and ACRIM. They're available on LFA's Lung Learning Hub. So there are 6 modules and they follow case-based scenarios through the modules. So we have a module that gives a bit of an overview of lung cancer in Australia, so different stats around incidence, mortality, survival, There's a chapter or module that gives an overview of the program. And then we have two modules, Module 3 and Module 5, which really deep dive into those steps of the pathway around eligibility and the low-dose CT scan. We have a module on effective communication strategies, so really mindful of stigma and lung cancer and needing to reduce that, and also communication strategies for priority population groups of the program. And then the last module is really a knowledge bank, so giving references to the resources that are highlighted in the modules, as well as other program-specific resources as well. There is also a suite of information materials that are being developed for the program for participants. And again, these are across the screening and assessment pathway and the program. So we have resources that, for example, FAQs that cover the whole program. And then we have resources which really are focused on specific steps. So for example, a brochure which explains to people why they might be ineligible to participate in the program and what they can do next. We then have a resource which is, outlining what to expect for the visit to the radiology clinic. So what a person needs to do before their appointment, on the day of their appointment, during that appointment, and after the appointment as well. And then we have resources which really explain the different results from the low-dose CT scan and what the participant can expect next based on that result. NACHO is now working to co-design these for Aboriginal and Torres Strait Islander people, and the department is also translating these resources into different languages. So a key focus for the new program is ensuring that the right people have the right information at the right time, and that includes healthcare providers, our states and territories, people from priority population groups, potential participants, and the general public. So lots of work has been happening in the communication and education and engagement space to help ensure that we are well positioned ahead of the 1st of July commencement. So we have a healthcare provider education strategy. So the department has engaged Cancer Council Victoria to develop and deliver a healthcare provider education strategy, really to support the dissemination of the materials that I've just outlined, with a focus on priority population groups. And this strategy is really leveraging existing networks such as PHNs, and also leveraging existing activities such as the GP cancer screening engagement kits, which are mailed out to GPs. They're now including information on the National Lung Cancer Screening Program. The strategy also leverages peak body and college networks, and does have paid tactics such as sponsored website contents, email, electronic direct mail, and podcasts. The National Communication Campaign, that will commence shortly, and that will be to raise awareness and promote the program to potential participants. The department has partnered with Cancer Council Victoria, who has engaged a consortium of suppliers to deliver this national campaign. So the initial phases of the campaign from July will focus on raising the awareness of the program among the general public. This will be via paid strategies, including television, radio, socials, and out-of-home advertising. And then we do have the National Lung Cancer Screening Program webpage. So all of the materials I've outlined today are available on the department's website. We will continue to update this as other resources become available. So I encourage everybody to keep an eye on this website for new materials and new information as the program is rolled out. It also links to those websites that I mentioned, the Lung Learning Hub and Ranska's website, which also house program resources. So this is a QR code that will take you to that website as well. I'll just stop sharing.
Thank you very much. That was great, Katrina. So we've got some questions they're starting to build up. So we'll have the Q&A session at the end. So just keep putting your questions in the box, and we'll hand over now to Daniel for his presentation.
All right. Good evening, everybody. And thank you for having me. I'm going to try my best to follow Katrina. And today we're going to talk a little bit about why we're doing National Lung Cancer Screening Program, and also the creative solutions that we are trying to come about with at Canberra Health Services to try and manage the high-risk findings, especially of that will be detected as part of National Lung Cancer Screening Program. Before I begin, I also like to acknowledge the traditional owners of the land which we meet today and pay my respects to the elders past and present. Lung cancer is actually the 5th most commonly diagnosed cancer, estimated almost 15,000 new cases. And that's 9% of all new cancer cases diagnosed in 2023. But it's actually the most common cause of death in Australia, estimated almost 9,000 deaths, or 17% of all deaths from cancer in 2023. To put things in perspective, that's more deaths than breast and prostate cancer combined. And what you see also is that colorectal cancer has a slightly higher incidence than lung cancer, but the death rate is 40% lower than lung cancer. This is the 5-year relative survival of the different cancers as per AIHW data. And what you'll see is that prostate, breast cancer, and melanoma 5-year relative survival are all more than 90%. For colorectal, that's 70%, but for lung cancer, that's 20%. Lung cancer is also disproportionately represented in Indigenous Australians. The 5-year survival for lung cancer is 12% in Indigenous populations versus 19% in non-Indigenous population. Mortality rate is also higher for lung cancer in Indigenous population, 59 per 100,000 versus 29 per 100,000. And the lung cancer age standardized mortality also increases with remoteness and more socioeconomically disadvantaged areas. What this shows is that most lung cancers is actually diagnosed quite late. Prognosis, as you see, in stage 1, which is the 10% at this stage that's diagnosed in stage 1, is actually 68% in terms of prognosis. Right, as of the latest data that we have from AIHW, 45% of lung cancers are actually diagnosed in stage 4, of which your 5-year relative survival is only 3%. In fact, we think that this number is potentially much higher than 45%, given that 28% were actually classified as stage unknown. And so, we've been wondering, can we do better? Can we diagnose lung cancer at an earlier stage? And there's 2 pivotal trials that happened in the NLCSP and the Nelson study. They enrolled patients for the NLST. They enrolled patients between 55 and 74 years of age, more than 30 pack-year smoking history. They will have to be current or ex-smokers within 15 years. And for the Nelson, they enrolled patients between 50 and 74. They had a somewhat slightly different, entry for criteria for pack years, but it equivalent to almost about 15 pack-year smoking history, and they had to be current or less than 10 years ex-smoker. What they found was that there was a clear 20 to 24% reduction in mortality in patients in the lung cancer screening group. The Nelson looked at having patients undergoing a baseline scan, and depending on characteristics, they were referred for definite management, or thereafter, their specific volume doubling time would merit a respiratory physician referral. So they had about a 2% referral rate, about 1% lung cancer detected in their cohort. And therefore, as part of this, based on the evidence of the NLST and the Nelson, there was an inquiry about the feasibility of starting a lung cancer screening program in Australia. And after you could see many different steps, we are finally at this stage where the program will be launched in July 2025. As Katrina already has talked about, NLCSP eligibility is for those aged 50 to 70 years, have no symptoms or signs suggestive of lung cancer, 30-pack-year tobacco smoking history, current smoker, or quit within the past 10 years. Katrina has already gone through this about promotion and awareness, screening eligibility, program entry, the actual lung cancer screening, low-dose CT scan itself, and what do we do about the results and management depending on whether you have a low, moderate, or high malignancy risk finding. Your patients might ask you about the potential benefits of the low-dose CT screening, and they might also ask you about what are the possible downsides of a low-dose CT screening. In terms of benefits, the clear benefit is about early detection of lung cancer, and because early detection of lung cancer could help us achieve better treatment options and a better chance of cure, as improve mortality 20-24% as per the trials from NLST and Nelson, and it's estimated that hopefully we'll be able to prevent 500 deaths each year from lung cancer. It's an opportunity for smoking cessation and support, and there could be some peace of mind as screening can help provide the patient reassurance that they they do not have lung cancer, or we are doing what we can to find lung cancer early. There are some potential harms of low-dose CT screening. It would be sometimes having there are a significant amount of false positives. Certainly, if you look at the NLST trial, there was a 24.2% positive result, of which 96% were false positives. But having said that, that depends on the way that you define positive result. And certainly Nelson defined a positive result based on the initial scan characteristics and also volume doubling time, and that resulted only in a 2% referral rate for the nodule malignancy, based on nodule malignancy risk and nodule growth, and about 1% lung cancer detected of the 2% that was referred. I think for our patients in the NLCSP, there's reassurance that the low and moderate risk nodules will be monitored appropriately. And then the high risk nodules, which we hope will have a similar referral rate as the Nelson study, will have specialist review. There's some concern about overdiagnosis. Now, overdiagnosis relates to because there could be whether we're going to detect lung cancer that may not necessarily affect the patient in their lifetime. There are certain things that affect the overdiagnosis rates. For example, perhaps the life expectancy, the age of detection, and whether and also whether the cancer itself is indolent, because and yeah, obviously for patients of which we detect lung cancer, there's obviously competing causes for death. But I think we can be somewhat reassured that when we look at the overdiagnosis rate, depending on how many years that we follow up the patient, it could be as low as 3% with extended follow-up. So for the NSLT, when they have a median follow-up 11.3 years after the last screen, I think the overdiagnosis rate may only be 3%. There's also some worry that can be generated from the low-dose CT screening. Getting a scan and waiting for results can be anxiety-provoking. The same way too, being told that you may have a low or moderate malignancy risk could also produce some anxiety, but we need to reassure these patients that they are getting the most appropriate monitoring for those findings. Exposure to radiation, again, it's only 1.4 millisieverts for a low-dose CT scan compared to the 3 to 5 millisieverts average 1-year background radiation, or 7 millisieverts for a diagnostic CT. So overall, we also can reassure our patients, even though there is some exposure to radiation, it remains relatively low. Incidental findings. Gareen had looked at the many different incidental findings that were found as part of the NSLT, and actually 34% had a significant incidental finding of at least one screening exam. most common being emphysema, though 12% also had coronary artery calcifications. There is now a guideline from the RANSCA in regards to additional finding for management additional findings. And you could see that for example, in a mild coronary artery calcified plaque, they suggest clinical review, constant lifestyle modifications, and pharmacological therapy. For those moderate and severe, clinical review, recommend lifestyle modification and pharmacological therapy. Similarly, every single incidental finding that has been that could be part of NLCSP has been clearly defined as per the guidelines. When you would require clinical review, when would you require referral to a respiratory physician, for example. Now, lung cancer screening uptake has been low in the United States and certainly less than 20%. And there was another study that had looked at maybe only 13% of those who were eligible were screened. But it somewhat depends on, I think, how we promote screening. And certainly when you look at a lung screen uptake trial in the UK, that was they achieved a 53% of 53% uptake. The participation in cancer screening in Australia has been quite good, especially in breast cancer screening and also cervical cancer screening. And in bowel cancer, for example, there's been an uptake of about 41%. And I know John has just updated me and said the latest data suggests 42% bowel cancer screening uptake. When we look at the data modeling for Canberra, we do expect that, again, I must say the modeling can be quite varied between which model that you choose to follow. But when we look at the latest modeling suggests that we'll probably detect 74 high to high risk findings in the next 12 months, which will require a respiratory physician review. And to put things in perspective for us in ACT, we also serve as a catchment area for Southern New South Wales. The last audit of our clinics in Canberra found that 42% of our current patients that we see in our lung cancer clinic come from Southern New South Wales. So in Canberra, we are looking at 176 additional referrals in the next year that could come from the National Lung Cancer Screening Program. And this will, increase the demand on the respiratory service, but also medical imaging, medical oncology, radiation oncology, thoracic surgery. It will also detect significant incidental findings, of which, again, if you look at the ILSD trial, we probably expect that maybe even though incidental findings are common, but perhaps 10% will be actionable. And although no funding has been provided to the states and territories to implement the program, we need to prepare and we need to adapt our service at Canberra Health Services to accept referrals from the National Lung Cancer Screening Program. But I consider this an opportunity for us to improve our service, improve our coordination of patient care. We've got to develop new interventional pulmonology services, and we've got to better collaborate between subspecialty services to deliver treatment. And as such, we are modifying our model of care for the respiratory service at Canberra Health Services to accept referrals to review high malignancy risk findings from the lung cancer screening program, and also review concerning findings suspicious for lung cancer from CT scans, not from the lung cancer screening program. As you know, we already run a suspected lung cancer rapid access service at Canberra Health Services. And what we're doing now is just adding in another component to accept in our referral criteria to accept high malignancy risk findings from the National Lung Cancer Screening Program. Otherwise, you'll find that on triage of your referral, depending on the risk that we associate with the referral that we receive from the non-lung cancer screening pathway, they will either be seen in a rapid access clinic, or those in the moderate risk ones will be seen in a nodule assessment, and thereafter, depending on risk, will be seen in rapid access or the nurse or registrar-led nodule clinic. Occasionally as well, as part of the nodule assessment, we find that, the patients actually had 2 scans 2 years apart in in different private providers, and actually no further monitoring is required. But this is a way for us to modify our existing service to accept now this high malignancy risk finding from the National Lung Cancer Screening Program. So this is our referral criteria for our rapid access clinic. It's those with a high for nodules that are detected as not part of the National Lung Cancer Screening Program. Then we look at those with a broad malignancy risk of more than 30%, a lung nodule or mass that's associated with lymphadenopathy, pleural involvement, metastasis, or invasion of any important structures, or a unilateral pleural effusion concerning for pulmonary malignancy will all be seen in the rapid access clinic. And now we're adding this a high malignancy risk finding from the National Lung Cancer Screening Program. And the only mandatory criteria is that we got to have a recent CT chest or a FDG PET scan dated within 3 months of the referral. Ideally, if you could also provide us with a family history of whether the patient has a positive family history, that will also help us, figure out the risk of a nodule or mass upon referral. And this is especially important for those who are not part of the National Lung Cancer, or for those nodules that are not detected as part of the National Lung Cancer Screening Program. We've also got a referral criteria for nodule assessment, and you could see that it's a very generous criteria. As much as we like to provide some support and guidance for all concerning nodules that you may have, and we accept a nodule for further assessment as part of our moderate risk pathway for moderate risk lung nodules for those who have a broad malignancy risk between 10 and 30%, a new solid lung nodule of more than 8, or a persistent or progressive ground glass or part solid lung nodule greater than or equal to 6 millimeters. And we also allow, reviews for nodule assessment for those patients who may not necessarily meet these 3 criteria, but the radiologist or the respiratory physician on triage is concerned about malignancy. Again, the referral criteria, the only mandatory criteria for referral acceptance is really having a CT chest or a PET scan dated within the last 3 months, and providing information regarding family history of lung cancer is a desirable criteria for referral acceptance. To conclude, the NLCSP is going to start in July. We have adapted our service to receive referrals from also the National Lung Cancer Screening Program and also the non-National Lung Cancer Screening Program CT scans that will inevitably detect many nodules. Refer all high malignancy risk findings from the NLCSP, and for lung nodules detected outside the National Lung Cancer Screening Program, moderate to high risk referrals will be streamed to the most appropriate pathways. And as mentioned, only mandatory criteria is a recent chest imaging, recent CT scan or a PET scan within 3 months, and as much as possible, if you could, information regarding family history of lung cancer, a positive family history being defined as a parent, sibling, or child having lung cancer. This helps us calculate the broad malignancy risk at triage. This will help us better allocate resources urgently to real patients with the highest risk, including those from the National Lung Cancer Screening Program, but also ensure that your referrals for moderate and high risk findings detected outside the National Lung Cancer Screening Program will also receive the appropriate care. Now, although no funding has been provided to states and territories to implement the National Lung Cancer Screening Program, I think it's an opportunity for us to better collaborate and provide the best care that we can for as many patients as we can within our current resources and despite the increased workload. And that ends my presentation for today.
Thank you very much, Daniel. So now on to John. He's the last of our formal presenters, and then we'll have the Q&A panel where we also have Jen Sloan from ACT Health Directorate and Professor Vivian Milch from Cancer Australia. So on to you, John. Thanks.
Thanks, Leonie, and thank you for inviting me to speak to everybody today. And a big thanks to Daniel and Katrina for their excellent presentations. Now, I'm going to provide you with an overview of the National Cancer Screening Register with a focus on the new National lung cancer screening program. And I'd also like to start by acknowledging the traditional custodians of country throughout Australia. I'm on the lands of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present, and to any Aboriginal and Torres Strait Islanders joining the session today. Now, the National Cancer Screening Register is essentially a digital platform developed to underpin the Australian Government's National Cervical Screening Programme and the National Bowel Cancer Screening Programme. And it's designed to support the end-to-end operations of those programs to help achieve the shared goal of eliminating cervical cancer by 2035 and also saving over 80,000 lives from bowel cancer by 2040 if we can increase the participation rate to 60%. Now, as we all know, after those presentations, the National Lung Cancer Screening Programme launches in July in just 7 days, and the programme will be supported by the NCSR. So this slide shows how the NCSR supports connected care across that screening ecosystem, with the participant at the centre of the NCSR having that single record for each participant across all programs. So if we start at the top there, we have our mail house that issues around 1 million items of correspondence each month, including reminders via SMS. We have a website where participants can submit forms and order bowel test kits as well. We've got a contact centre taking around 6,000 calls each week, and a portal for participants to check their last and next screening action, amongst other things, which is available via MyGov. And the NCSR has connections with Medicare for participant demographics and up-to-date contact details, the health information services, as well as the provider directory services. And that's used for healthcare provider authentication in the back end. And all this national data is accessible to authorised representatives, so that maybe within the state and territory governments, within the federal government, and also within the Australian Institute of Health and Welfare. And our digital channels and integrations on the left there, so those are for healthcare providers and labs, and help us move away from those old days of having to call and fax the register or the lab to access results, and provides that self-service way to access the information that you need. Now on this slide, we can see how the NCSR supports the National Lung Cancer Screening Programme specifically. So the key difference in the NCSR supporting the lung programme versus the bowel and cervical programmes is that the participant is enrolled in the programme by the healthcare provider, as Katrina mentioned. So at step one there, the GP refers eligible patients to receive the low-dose CT scan and enrolls the patient into the programme via the eligibility and enrolment form within the NCSR hub in your integrated clinical system. If you're not integrated, that can also be done via the healthcare provider portal, where the functionality is essentially the same, and that's accessible within PRODA. Now, on that second step, we've got the radiologist assessment. So the radiologist conducts the assessment using the NLCSP nodule management protocol and submits a structured report and overall recommendation to the referring practitioner, or GP, and also to the NCSR, so it can act as the safety net for the program. So the NCSR takes those results and uses all the information held about the participant to apply the correct screening pathway as per the clinical guidelines. And this then updates the appropriate recommended next action and issues the appropriate prompt, whether that's a letter to the participant to screen again in 2 years, or a phone call to a provider to understand if the participant has been referred to a specialist. Now for number 3 on the screen there, that's the specialist referral. So if the participant is at high risk of lung cancer based on the LDCT, they'll be referred to the specialist, and the specialist will determine the diagnostic pathway. So that's an opportunity for the referring practitioner to also inform the NCSR where that patient has been referred in a similar way that you would for the cervical or bowel programs. Step 4, the specialist sends the clinical diagnosis form to the NCSR, and this can also be done via the digital channels, like the healthcare provider portal within PRODA. And step 5, the histopathology reports will be transmitted automatically from those integrated laboratories directly to the NCSR to support lung program reporting. Now, I'm sure many of you, if not all of you, are familiar with the NCSR functionality. So we have the healthcare provider portal, as I mentioned, which is built into PRODA. And we have the integrated functionality, which is integrated with Best Practice Premier, Medical Director, Clinical, and Communica. And we've got really high rates of integration within the ACT, around 72%. So I know many of you will be familiar with that functionality. The functionality within both systems is essentially the same. It's just that little bit easier when it's integrated into the system, because it's in the system that you are working in throughout the day, and you can access the NCSR record directly from within the patient record, rather than going into PRODA, logging in and searching for the participant that way. But the functionality is essentially the same. So you can access patient screening records, results and histories online in the next screening action, submit program forms electronically, manage patients' details and preferences, and also order bowel screening test kits to arrive directly to the patient's address. Now, we've got around 4,000 practices integrated across the country, and we've got 25,000 active users of the healthcare provider portal functionality within PRODA. And as that adoption has increased with the integrated functionality, we can see a big move away from faxes, with about 94% reduction on faxed cervical screening history requests. So we've gone from about 8,000 faxed history requests a month down to about 270. And now we can see, as a kind of a proxy for usage, we've got about 40,000 cervical screening histories accessed through those channels each month, which is fantastic. Now, I wanted to also show you how to enroll someone in the new lung cancer screening program. Now, many of you use different software. So for this demonstration, I'll show you how it's done through the healthcare provider portal in PRODA. But essentially, the functionality is the same, whether it's integrated or whether in PRODA. The benefit when it's integrated is, of course, you don't have to search for the patient. You're already in their record. So this is the front screen of the healthcare provider in PRODA. We're searching for the patient there with the identifiers. You can use a Medicare number and a DVA number, a register reference number as well. And we can see that the person is not active in the lung program. So as soon as you hit that button, it goes straight to the enrollment form. And the healthcare provider details are automatically included because we know who's logged in. And we go down to a number of questions. Are you operating in an ARCHO? Is the patient eligible based on the criteria? Has the patient declined to participate in the program? And provide the privacy notice there. The patient suspends NCSR contact. They remain a program participant but will not receive correspondence. And is the patient suitable for an LDCT? Has it been provided with smoking cessation support? And what is that? And does your patient have a family history of lung cancer? Also collect demographic information there, so Aboriginal and Torres Strait Islander status and country of birth, as well as the preferred language spoken at home. You can then review that information, hit submit, and the patient is then enrolled in the program, and you can view that form that has just been submitted there. You can also see that under the alerts tab, that this patient is eligible for the NLCSP and has been enrolled into the program. Now, there are a number of resources that Katrina touched on, and there will also be a number of resources available from the NCSR as well. So we already have a primary care onboarding toolkit, and this is used to help practices access everything they need to access in relation to the NCSR in one place. So it gives information about how to integrate the practice software, how to access the healthcare provider portal if it's not possible to integrate the software, if you're not using BPMD or Communicare, and also how to access additional support if you would like some help with actually integrating and setting up your practice to access the NCSR directly. So if you are facing any issues, we have a link which is included in this toolkit, which essentially it's a booking link. So you can book in some time with one of our experts and they can walk you through the whole process. Now, this is being updated right now, and as at 1 July, this will also have further details on the National Lung Cancer Screening Program as well. And we'll make sure that you receive this onboarding toolkit after the session. And that's everything from me. Back to you, Leonie.
That's great, John. Thank you very much. I think I'll just start with my own question. Sorry about this, everyone attending. But so you've enrolled a patient onto the National Lung Cancer Screening Program through PRODA or your integrated software access. And now you want to print a form or send a form to a radiology company. So 2 questions. How do you register on the form that they're part of the National Lung Cancer Screening Program? And Jen, which radiology companies are participating in Canberra?
I can take that. I'll go first if you want. Good evening, everybody. Jen Sloan is my name. I'm from ACT Health, and I'm supporting locally the implementation of the program here in our jurisdiction. We're quite well prepared in terms of our privates. So at this stage, we have 23 confirmed sites who are going to be participating. That's all the major private providers. So I just got my notes: Qscan, Canberra Imaging Group, Loomis, IMED. We also have Canberra Health Services who will be also providing imaging as well. And they'll be able to provide bespoke imaging, particularly for those who might need additional support in their imaging. They might have limitations in their mobility or other confounding issues. So we are very well placed in terms of pathology and, radiology. And in terms of the form that we want to be using, Katrina referred to that form in her presentation. That is the national form that has been provided by Commonwealth. And you can actually just Google that. It's also on the National Lung Cancer Screening Program. It goes to all the specifics that Daniel was talking about as well around family history, if it's a repeat scan. So all the details are on there for the radiology providers who will actually upload that detail into the NCSR as well.
And so do you need to be specific about which site you're sending the patient to, or you fill out the form and they find the site?
Strictly speaking, they will find the site, but we're very lucky. We're just about everywhere. We'll find this. We'll be providing this in the ACT. The form, I haven't looked on the form in that detail to see whether you have to notify the actual provider. I don't believe so. Katrina, do you know?
I don't think so either. Let me just double check that while we're on.
So I think it's Vivienne Milch speaking from Cancer Australia. I'm here together with Katrina. Look, my understanding is that the only things that you need to put on that form are that they're a National Lung Cancer Screening Program participant, that they do or do not have a family history, that they have or have not had a CT scan in the last 12 months. Other than that, the person just takes the form, and that all that information can be used for the radiologist to charge an MBS item for a National Lung Cancer Screening Program.
Thank you. Thanks. Okay, so we'll move on to the questions that have been typed in. So the first question, I guess, would go for Katrina potentially as well on this one. How will bulk billing of the test be facilitated for private providers? Is the MBS fee higher than the diagnostic chest CT MBS rebate, or do private providers, I don't think they have the discretion not to bulk bill if it's not financial viable. I think if they've agreed to be part of it, they have to bulk bill the National Lung Cancer Screening Program.
Yes, that's correct. So the 2 program-specific MBS items are those mandatory bulk bill items. In terms of the price, it was set in line with the existing MBS items for CT images as well.
And following on from that, maybe this one's for you, Jen. Sorry to target you again. Sounds like there's a bit of paperwork involved in enrolling patients. Is there going to be an MBS item number for GPs for doing the eligibility assessment? So maybe not for you, maybe more for Katrina or Vivian. Sorry.
No, all good.
Yes.
Yes, so there isn't those MBS items for the eligibility assessment. Encouraging to use existing consultation items and consultation items, and also health checks such as the 715 health check for Aboriginal and Torres Strait Islander people. NACCHO is currently working to get that health check form updated to include the National Lung Cancer Screening Program as part of the health check as well.
So the next question is, what are the requirements for enrolment? So you've talked a bit about the eligibility, but I think this one was wondering if there's any different situation for DVA.
That's a good question.
So I think it's my understanding is that it's just a mandatory bulk billed MBS item, regardless of all you need is a Medicare card. So there's no difference for DVA.
Right. I think we've already answered this question, Daniel, with the counselling about the radiation risk. So we'll move on, and we've already answered the question about private providers in Canberra accepting the low dose CTs. This one is for you, Daniel. It's please comment further on the 94% false positive rate.
Oh, yes. I need to be more specific. We just looking at nodules as a whole, right? 94, again, this is how the NLST define a positive finding, which is a nodule that is 4 millimeters and above. If you look at nodules as a whole, the majority of nodules are going to be benign. In fact, if you look at the PanCan study, it suggests 99% of the nodules were benign. So in our cancer program, I think it's going to be more similar to Nelson. And when you look at the referral rate of Nelson, for those with high malignancy risk findings, you expect that probably about by that time, because it's been the nodule has been judged as very high malignancy risk findings. By the time you refer to the respiratory physician, you might get as high as 50% malignancy rate in those patients who are being referred. So if you look at nodules as a whole, most nodules are benign, but then again, that's because you're looking at any nodule that's more than 4 millimeters. But if you're looking at the very high risk and high risk findings that are being referred to respiratory services, you're probably looking at a malignancy rate about 50%.
So a bit more, yes, quite significant.
I don't know whether we want to add to it. Yeah.
I might add just a few comments about that, because the risk of false positives is something that worries everybody. Nobody wants to be finding lots and lots of people with who are worried but have a false positive. There's been a whole lot of things done in the program design to try and manage false positives, and one is that all the radiologists are all going to report every scan in the same way. And that's according to a nodule management protocol. So they're going to be very specific about reporting every nodule according to a specific way. And then every nodule has a very specific follow-up schedule, either a repeat scan at 3 months, 6 months, or 12 months, if there's a low or moderate risk nodule, or as Daniel said, those high risk nodules or very high risk that are then referred straight off. And for those people, there's a very low risk of false positives. So it's the whole program has been designed to minimise false positives and to minimise the number of people who will have to be investigated who actually don't need to be.
That's good, thanks. Okay, the next question is about people moving locations and how they'll be followed up. So how will patients who move location be followed up, as the program will require a lot of repeat imaging? And I think you're trying to get people to go to the same imaging location for each of their scans.
I can talk to the NCSR follow-up. So we have a follow-up team that will call participants and their healthcare providers to identify the information required to make sure that the people are following the next steps on their pathway. And the register, it has a direct connection to Medicare. So we receive updates from Medicare on a daily basis. So that's one way to try and get as much up-to-date information as possible. There is also the option within the functionality, so within the integrated solution, for the healthcare provider to update the patient's address and contact details held on the NCSR as well. Now that doesn't update Medicare, but it does update what is on the the patient's NCSR record.
You want me to just to add, I guess on the structured report there is section for identifying the radiology clinic and radiologists, so that the kind of next scans can have that history of where the previous scans were undertaken. And the low-dose CT request form also includes information on the date of the previous scan and, if known, the radiology location as well.
Would you like people to be going back to the same machine every 2 years?
I think that's best, yes, and encouraged, yeah.
So the next question is also for Katrina about getting the forms. So are they, once you've enrolled in through PRODA or your integrated NCSR hub, are the forms, do they come up, or how do we access those forms?
John, do you want to take this one?
Yeah, so is this the question from Tracy? So how do we get the request form?
And the one from Quigley and above. So when will the resources shown by Katrina?
They are, yes, so they are being sent out by the Cancer Council Victoria and the dissemination strategy at the moment. So they should be coming very soon.
Right.
But otherwise, I can reshare. I'll put the link in the chat in terms of the page which houses all of the healthcare provider resources as well.
So we've got another one about, so there's a few defence people with gold cards, so they don't have Medicare cards anymore. And how do they get integrated? Is that a John question?
I think that's a good question.
Pardon? It's a Jen's question?
No, I'm handballing to Viv. I think that's...
Look, actually it's the first time we've ever been asked that question, which is saying something, because all of us have been on many of these. I think that they would still be integrated with the NCSR in the same way, but maybe it's a question we could take on notice for the Department of Health, Disability and Ageing to get back to us, because my understanding is that nothing would be different. They'd still be integrated through the MyGov to the same, through to the NCSR. They'd still everything is still function in the same way. But Leonie, it might be useful for us to actually get that question back to you.
Yeah, I think that's a good question. Yeah. Yep.
So, sorry, when I had the word integrated, I was instantly going to healthcare provider functionality integration. So in relation to DVA, the NCSR has a connection with Services Australia. So we also ingest the DVA numbers as well. So that is used as an identifier for a participant in the same way that a Medicare number is.
Right, okay, that's good. So I had another question. So people now are vaping, not having pack year smoking. What do we do about them?
So I might take that. The National Lung Cancer Screening Program was developed based on the available evidence that we have, and that is based on people who smoke. So the eligibility criteria is only cigarette smoking. It is not vaping. It is not passive smoking. That's not to say that it might not change in the future. This is going to be an agile program that will be evaluated regularly. But at the moment, vaping is not part of the eligibility criteria.
Right. Yeah. So we've come to the end of our questions. If everyone would like to have a kind of a closing comment each, and then we can wrap it up for the night. So, John.
Yes, there was just one question I'm not sure if we answered. So there was a question around forms. So there's a number of forms built into the NCSR functionality, such as the eligibility enrollment form, but the request form specifically, that is built into Best Practice Medical Director, Communicare, and MMEX. And depending on which software you use, if you can't see it now, it will be available on 1 July. That specific request form is also on the Department of Health, Disability and Aging website. So if you just search for NLCSP request form, it should come up at the top of the list. But closing comment, if anyone would like any further information about how to integrate their practice software, I'm not sure if you are integrated, please do give us a call and we'll make sure that you get access to that primary care onboarding toolkit, and everything you should need should be in there. But hopefully we can help more practices get on board. Thanks, Leonie.
Right. We have got one more question. I'll leave it for Daniel at the very end. Jen, any closing comments?
I think to reiterate what Daniel had said and what Viv has said, this is the first new program in 20 odd years, screening program. We're at the start of it. It's probably not going to be perfect, but it's better than nothing. And I just want to reiterate that. So I've said this to some participants offline. Breast cancer screening didn't start where it is today. So we expect that it's not going to be perfect. And I think we just appreciate going in that this is going to be better than nothing. And I think the other thing is that the ACT, given its size, is actually very well placed to be ready to start this program. And we're incredibly lucky to have Daniel and his team already have an existing urgent lung cancer clinic there and ready, that they've been agile enough to go with that. So just a congratulations to him and his team, and thank you. Looking forward to seeing how it goes.
Thanks, Jen. Katrina?
Thanks. I think, reflect on what Jen just said, and it is the first new program in 20 years. It's a really exciting milestone to be now, a week out from the program commencing. I think, highlighted a lot of resources today, and we have developed a lot of material information to really support healthcare providers and participants and the general public. So, please reach out if you don't see those materials coming through your practices, and we'll be sure to get them sent out as well. And I have put that link in the chat as well, so you can access those tonight as well.
Thanks, Jen. And actually, Vivian, maybe you want to answer the last question, and then you can give your closing comments. So the last question is, so if a patient requires a 6-month follow-up CT scan and they go to a different provider, is it up to the radiologist to locate the previous images so they can be compared?
Yes, is the answer to that question. Bottom line is that all of the results will be accessible to the radiologist, but not the actual images. So if the person goes back to the same radiology provider, they'll have the images there. If they go to a different radiology provider, the radiologist will be able to find out where the initial provider was, either through the patient themselves or on the NCSR, because it will be recorded there, and they'll need to access the images and compare them. So not ideal, but definitely possible. I'd like to make a closing comment, and it comes from the fact that I work across all the screening programs, breast, cervical, bowel, and now lung cancer screening, and I'm also a GP. And really what I wanted to say was that we have in front of us a cancer that is usually diagnosed late, because that's when you get symptoms, often at stage 3 or 4. It is the biggest cancer killer in Australia, and Daniel presented those stats in a very clear way. We have an opportunity to find lung cancer at an asymptomatic stage when you can do something about it, whether it be surgery, radiotherapy, or systemic treatments. We have an opportunity in general practice to find those patients before the sort of cancer that we've probably all seen of someone just presenting late and doing poorly. So as Jen said, we don't really expect this to go, it's new and it's different. It's a new pathway. We've all got to get used to it. But it's an amazing opportunity that we've been given to change the course of lung cancer in Australia.
That's great. Yeah, thanks. And lastly, Daniel.
Okay. So thank you everyone for having me and humoring me in this time where I get to present about the CHS program. I'm going to say that, we're all going to be working within our current resources, and as much as possible, we'll endeavor to come up with a program that is as inclusive and as accessible as possible. I'd like to invite you to also provide feedback, and I certainly will reach out through our GP channels in a few months to have feedback about how we are doing and how we can do better at Canberra Hospital. I'd like to invite you also to be part of our working group. So we've got 2 GPs who attend part of our working group about for our new model of care. But if you'd like to join, consider joining our working group, or you'd like to get some updates regarding our working group, my email is daniel.wang@act.gov.au, and I am looking forward to better collaborate and understand also from the general practitioner point of view how we can do better to service your patients.
Thank you so much, everyone. That was really good. It sounds like you're all very passionate and excited about this, and we should be too. And we can do that by enrolling our patients and getting ACT off to a good start. That winds up our presentations for the night. We'll put a recording of this on our Capital Health Network YouTube page. So if you want to check back in and if you've missed anything or you want to share it with your colleagues, it's there. And CPD, please feel free to record, self-report 1.5 hours of educational activities to your CPD home, and we'll be sending you out a certificate of attendance and an evaluation form, which I'm sure you'll rate very highly because there was such a great presentations by everyone. So thank you all very much and good night.
Thanks.
Thank you.
Thank you for having us.
Thank you.